Hello everybody. Today we are going to talk about wound care, not sterile wound dressing changes, but when you have a dirty type wound. So if we're looking at Mr. Butts here, you can see that there are several types of wounds that he has. We're going to actually change his stage 4 dressing. But before that, we're going to talk about the different stages of wounds from pressure that we can see. So our first stage, stage 1, now as an LPN, you're not going to actually stage these wounds. And of course, I wouldn't have my hands on the patient's butt without gloves on. I would like to just say that. But you do need to know what they look like and to notice if there's a change that occurs so you can report it to the RN or the provider. So this is a stage 1 pressure ulcer. You can see it looks like the patient has been laying in bed and has been incontinent. So you talk about unblanchable redness. So that's if we can push our finger on here and it doesn't change color. So you can see Mr. Butts clearly has a stage 1. The skin is not open, but it is red. So we move over to his side, you can see that there is a stage 2 here, where the top layer of skin has been removed and now the wound is open to the outside world. So this is what we would call a stage 2 pressure ulcer. It looks very different. Stage 1, stage 2. So on to stage 3. So stage 3, you can see, has some underlying subcutaneous tissues involved in the wound. Often you're going to see deeper margins here and redness in the wound bed. And then stage 4, we have some bone involvement, and that's what that's supposed to be there. It's the sacrum. This particular wound, when we go to talk about dressing changes, you're going to see that there's tunneling present at the 1 o'clock and the 9 o'clock. And so should we talk about the clock now, Miss Palmer?
Sure, I think that'd be good.
Okay, so if I am looking at this patient, generally they're not going to be laying on their belly to do wound care, but you'll be approaching it. So if I'm going to approach it from the side like this to do a dressing change.
So I'd be like this, right, Miss Canby?
Yeah, yes, Miss Palmer. So you're going to look at the patient like a clock. So what's it usually at the top of the hour, Miss Palmer?
I think that's 12 o'clock, right?
12 o'clock, right. So 12 o'clock clock is also going to be where the patient's head is up here. And 6 o'clock would be the bottom of the clock. So where we get 1 o'clock is 12, 1. So you can see there's a little bit of tunneling. I don't know if you can zoom in there and see there's tunneling at 1 o'clock. 1, 2, 3, 4, 5, 6, 7, 8, 9. And then you can see we have another wound there that's tunneled. So 9, 10, 11, 12, and then we're back at the top of the hour. So when we're doing our dressing change here in a minute, we're measuring the tunneling, and I say 1 and 9, now you know which areas where we have identified. Okay?
What's the point of that, Miss Canby?
Well, the point of that is so that we can tell from nurse to nurse where it's located. So if I say it's on their left upper part of the wound, well, it depends on which way you're looking at it. My left upper, if I'm staring down at the wound this way, is up here. If you're approaching it from where Miss Palmer is, that's going to be up here. So it's really just so that we have one system to go by and we can measure, and it'll be the same across universally.
Okay.
I guess is a way to say that.
That makes sense.
Okay. So, are we ready to get dressing this wound?
Yeah, I think so.
Okay. So we have gotten in reports that this patient needs their stage 4 sacral dressing changed on our shift, and we are so excited because as a student nurse we don't get to do that very often. So first thing I want to do, obviously, is I'm going to have a relationship with the patient. So I'm going to have gone in, done my AIDIT, explained what is going to happen prior to the dressing change, and then what are we concerned about before we do anything to the patient that might be uncomfortable.
I think you're probably talking about pain, right, Miss Canby?
Yes, Ms. Palmer, that's correct.
Okay.
So we want to make sure that if this is a painful procedure that we're doing to the patient, they have been medicated prior to the dressing change.
Yeah, stage 4 sounds like it's pretty painful.
Yes, that's correct, Ms. Palmer. Generally, patients with that bad of wound do have a lot of discomfort just by laying still or even indefinitely with their dressing changes. So ideally, before we would go in, we would have gotten an excellent report and we would know the things that we need prior to our dressing change. So you can see here, I have our irrigant, some gauze to pack the wound with, some gauze 4x4s for on top of the wound, tape because we want to make sure we date and time and initial it, our little Q-tips, sterile Q-tips, so we can measure that tunneling in the wound and measure depth and width, which also has a measuring stick here on the package that you can use, but because I'm afraid I might get too rowdy and pull that apart and rip it open, I also have this measuring stick here that we can use. So both of those are available for my use, and I brought both of them. So before I get started, our patient is comfortable and they know what we're going to do. Personally, this is my kind of thing, Miss Palmer, so indulge me for a moment.
Yes.
But I like to make sure if I'm doing a dressing change myself or with students that my hair is pulled back and that I don't have anything that's going to fall actually into the dressing. So this, like my stethoscope or my badge. So I'm going to just tuck those aside. So now I don't have anything that's going to actually dip into the wound. Also, you notice my sleeves are pulled back so that I'm not going to take anything and rub it across the wound and then rub it somewhere else. So that's just me. So I am going to wash my hands, of course, first. Make sure they're nice and clean. And then we are going to apply gloves. Make sure my hands are dry.
This is why it's so important to let the hand sanitizer
That's
dry.
right.
She's just testing you guys.
I was rushing it for the sake of
Mm-hmm.
myself being on this screen here. Okay. Less time in front of the camera. All right, so I have both of my gloves on. So I'm going to remove the dressing. And again, this is pretty easy to remove, but you can always pull against the skin a little bit to make it more comfortable to the patient as we undo it. Okay, so I pulled off this top layer. And one of the things I'm looking at here is to make sure that I have all the supplies that I need for this dressing change. So I do have my top gauze that I'm going to use there. And then here's my packing. Oh my goodness, what is this, Miss Palmer?
I don't know who did that prior.
Why would this be a problem in packing a wound?
I don't know. It looks okay. It looks clean.
It does?
Mm-hmm.
I don't think so. What would be the problem of having 2 or 3 or 4 or 5 different pieces of gauze in a wound that we're just stuffing in there?
I don't know.
I think maybe as students they should think about it and get back with us, right?
Okay, when they come into the lab, let me see if they have the answer.
Okay, good idea, Miss Palmer. So, get that answer. So we're going to throw this away as well. Okay, so we've taken all of our stuff out of the wound. So now if we have orders, we can clean the wound. Now we don't want to just get all super excited as students and get in there and scrub every wound that we've come across. So I'm going to check my orders. My orders say, we can clean it. Okay, So this wound is obviously on a mannequin, so it doesn't have any exudate on it or drainage. So if we had noticed drainage color, that would be one thing that we would want to document, the amount and the color, and any exudate that is in the wound or on the gauze. So if we had maybe some serous drainage, are we concerned about that?
I don't know.
Or how about some greenish yellow drainage?
That seems worse.
Another thing that you want to think about and reflect on as student nurses, because I'm not going to give you all the answers.
Mm-hmm.
So we've opened up the wound and now we can clean it.
Mm-hmm.
Okay, so I'm going to take my gloves off. Wash my hands again. And then get ready to clean the wound. Now, this is where I want to make sure that we all do it the same, but there are some variations. Now, I have a tub of gauze here. One of the things that you can do is you can open it and you can, depending on how much packing you need, if you needed one gauze, you could pour a little bit in here and use a gauze to clean it and throw that away, and then use a gauze to pack it. But Mr. Butts, we're going to use the Curlex to clean or to pack the wound. Does that make sense?
Yes.
Okay. So I have that open, and I'm not going to saturate it all. So I'm going to keep this dry right now.
So Miss KMB, why are you not putting sterile gloves on?
That's a very good question, Miss Palmer. So at the beginning of the video, we talked about that this is not a sterile wound. So this wound is what we consider dirty. Now, dirty, that doesn't mean we want to go outside and get dirty ourselves and then put more dirt in there or sneeze in our hands and do the dressing change. That's not okay. It just simply means that it doesn't require sterile dressing. Some of the dressings that are sterile, Miss Blackmore will discuss with you. And those are generally your post-operative dressings where we don't want the sterile environment that was created in the OR to become contaminated with our everyday run-of-the-mill bacteria. So this is not that case. This probably came from a patient that was incontinent laying on their wound for a long period of time. So we're just going to do it clean. Does that help, Miss Palmer?
Yes, I was wondering why they called it dirty. I thought that meant there was a lot of infection in there or something.
There can be, but that's not always the case.
That makes sense.
Mm-hmm. So we have our irrigant here, which we would want to make sure has the right date and time on it, which it does. If it was new, we would date and time it, and it's only good for how long?
I think it's 24 hours, didn't you say?
I think you are correct, Miss Palmer.
Mm-hmm.
So if we're going to open a new one, or a dirty one, we would lip it. So we're lipping it. Okay. And now I'm doing this over the top of Mr. Butts because I'm doing it so that you can see. Now, normally I wouldn't be standing over the top of him like this, preparing my dressings.
Mm-hmm.
So just keep that in mind. You don't want to be doing all this stuff over the top of your patient. So I am going to try not to contaminate my gauze. So if I grab a gauze to clean, I don't want to do like this. It's not a dirty tissue. So we want to be precise and careful with what we're doing. So I'm just going to grab the corners to make a little poof. Okay, so I can clean it. So I'm taking my irrigant and I'm going to get it wet. And if I need to, I can squeeze it out a little bit, but we're really just cleaning the wound. So depending on where you go, depends on whether you use strokes or do a circular motion in cleaning the wound. The most important thing is that you're doing clean to dirty. And even though this is a dirty wound, you want to go from the inside of the wound, or the part of the wound that has the least amount of exudate, to the outside of the wound. Because what will happen if we go like this?
Oh no, it looks like it's going to sweep more bacteria inside the wound.
Right. So we don't want to, and I'll talk about this in reproductive, we don't want to sweep dirt into the house. So we want to make sure that we're not putting anything from outside of the wound that's more dirty, whether it's fecal material or urine or staph or dead skin cells, whatever it may be, into our wound that we're trying to get to heal. Because remember, wounds heal from the inside out. So we want to keep that clean and help initiate that good granulation tissue. So this one, I already said, oh, we swept the dirt in the house with, so that's no good. We're not going to use that. So again, we're going to make our little poof here. So see, I haven't rubbed it all over. I'm going to get a little wet. And then we're going to clean from clean to dirty. So I'm just going to do, we'll use strokes in this case and remove it away from myself. So I'm trying to avoid this area here because I'm on the mannequin, you can't really tell what's going on here. So it could be some muscle, or it could just be some yellow exudate. I'm not sure, but I'm just going to clean this area over here first, and then we'll get this one second. And then we would clean the outside of the wound there. So now we haven't put anything from outside of the body inside of the body, right?
Yes.
Okay, so I've cleaned the wound. So I'm good. So this is where we differ between clean and dirty wounds. So in a sterile wound, we would wait to do our measuring until we have our sterile gloves on. Because what did I say? You have that beautiful OR with the nice, clean, sterile field. We don't want to take our dirty gloves, dirty because they're not sterile, and start poking around in there. However, this is a clean procedure. We're not going to put sterile gloves on at any point, so we can measure now, or we could measure before we cleaned it. But this way, we're able to visualize the wound, and we've removed any exudate that might be on there. So I'm going to get my cotton tip applicator, and I'm going to measure. So we want to measure our depth of the wound, and it looks like this individual has the same amount of depth all around. So we can do that. Now you'll see some people measure this way, some people will measure this way. Right now we're just going to use the tip of the Q-tip. So I'm going to mark my spot here, can you see that? And then measure up against the package here. So it looks like it's at 1 centimeter. For our, what's this part called?
I think that's the depth.
Okay, so yes, that's the depth. So then we're going to measure width and length. So width is the widest part of the wound. So if you sung the song as a child, deep and wide, deep and wide, that's where this comes in. We're going to measure wide, deep, and then long. Or if you do carpentry, but I know nothing about that. So we're going to measure here. And that's going to give us the width of the wound. And I'm going to bring it over here to my measuring tape. And it looks like it's 5.5 centimeters. And I guess would you like for me to do this, Miss Palmer?
Sure, that'd be great.
So that they can kind of see here the comparison. Does that help?
Yeah, we'll have to look at it in the lab too, because it is hard to see on.
Yes, it is. I do agree. It's hard to see. So I'm going to put that down there. And then we have length. So length is also going to be measured like this as well.
And how is this measured, Miss Canby? In inches?
No, in centimeters. Because and this is the same thing, it's 5.5 centimeters. Because hopefully we don't have a wound that's 5 inches. Because what does 5 inches look like compared to 5 centimeters?
Oh, that's good critical thinking, I think.
Yeah, so this is 5 centimeters. And this stick is probably 4 or 5 inches, I would say. So just kind of think about that. whenever you're doing your measurements. So now, do you remember the tunneling we talked about? So we talked about having tunneling at 1 o'clock and at 9 o'clock. So now I'm going to measure my tunneling. And what we're going to do there is I have my tunneling, and I'm going
What
to...
if you can't see it, Miss Canby? Like, it's really hard to see in a wound, right? Is there a way that I can feel for it?
Sure, you can feel around in there.
Okay.
Now, again, you don't want to do that with dirty gloves.
Mm-hmm.
But yeah, you can feel around for it. And again, you want to not be poking around because we discussed that this might be painful.
Mm-hmm.
But you can run your finger along there to find out. So I've run my finger and I kind of caught the tunneling here at 1 o'clock. So I'm going to measure it. And it looks like, and I took this side because this was too wide to measure my tunneling. And I don't want to, of course, jam or force anything into the wound. So we don't want to make it worse. So I'm just going to go like this, gently put it in there, and again, put my fingers on there so I can measure it. And what we pull out is a measurement of, it looks like maybe a centimeter to a half a centimeter. So this is actually a centimeter. Okay, so we would document with tunneling at 1 o'clock with the depth of 1 centimeter. Okay, so now we have the one at 9 o'clock, which we've identified. Oh, there it is. And this one looks like it's a little bit deeper. So this one is it's about 2 centimeters. Okay, so that is how we measure the wound. So what do you think we should do, Miss Palmer, with all these numbers? Am I just going to remember them as a student nurse?
Well, no, here, I'll hand you a pen.
Yes. I do have a pen. Oh yes, I do have it. Hold on, I do have it.
Good, okay.
I do have a pen.
Oh, gosh. I think you might be breaking a lot of rules with standard precautions, Miss Canby.
Well, what do you mean, Miss Palmer?
Well, I think you're just touching that wound with your gloves, and now you're touching your pen, now you're touching your face, and you put the Q-tip in your ear.
Oh, I'm so embarrassed.
Yeah.
Oh, no. Okay, I guess I better not do that then.
Right.
So, let's rewind. So, Miss Palmer, how would I go about having all these measurements written down?
Well, if you had to write them down, I think you would have to take your gloves off and wash your hands before you can grab your pen, right?
Yes.
Or would it be okay for me to write them down for you?
I would love that. That would be even easier for me.
Okay, I'll write them down. So I got your pen here. Just tell me what you want me to write.
Okay. So we want to do the length, width, and depth. So our length was, whatever it was, 5 centimeters. So was our width, and our depth was, I believe it was 1. And then we would chart about the depth of the tunneling at the 1 and the 9 o'clock. Okay. So it's good to have a partner when you're doing this for the first time. So these are all dirty. I no longer need these. But it also brings the good point of, if we have to do any documenting or keeping track of everything, or need your scissors or whatever, that now is the time to get that stuff out, because you don't want to go reaching in your pockets where you keep your lunch money and then go get lunch later with your MRSA all over it. So I have my scissors and I have my Sharpie. Why do I need a Sharpie? So one of the things that we're going to do, and that is mandatory at all of the Rochester Regional Health System facilities, is that we need to date, time, and initial the dressing when it's done. So if you were the patient, would you appreciate me doing your dressing and then writing on it like this?
No, that doesn't seem patient-centered.
No, it's not nice. So it's also very unprofessional. So I'm going to, ahead of time, take my piece of tape off and mark it. I also know that I'm going to want 4 pieces of tape to window pane my dressing. So I'm just going to get those ready now because that's my preference. And I should have probably put the cap back on there. Okay, so I'm just going to set these here. Now, if I was not doing this on, I don't know if you can see it or not, on camera, you can't really see them, but I would put them over here close to me. So I have my 4 pieces of tape.
How much should you cut, Miss Canby?
So you want enough to just go around the dressing.
Okay.
If you get it on there and you are new at taping things because you were all new at that, and you don't have enough, then you can pull out another piece later. But this way, I'm not trying to fight with the tape with my gloves on later.
Okay.
And that's just a personal preference.
Okay.
So now I'm going to put my date and time on here. In military time.
Oh, that military time is tricky.
You can get it, just add 12 to whatever time it is. So I've got my label here. So now I have everything ready as far as that goes. So, Miss Palmer, are we doing a wet to dry packing?
I think that's what the doctor ordered, yes.
Okay. So if I'm going to do wet to dry, I am going to need to wet my gauze. So again, I've got my clean hands, so I'm going to get my stuff ready. And I'm going to open this up, and again, I don't want to have my hands all in here and everything because that's not best practice for the patient. I'm opening it up away from myself. Got my scissors out because when I start packing the wound, I'm going to need to cut my gauze. So I need to have my scissors ready. My Sharpie, I don't need anymore, so I can put that back in my pocket. So again, I would lift this, and then I'm going to moisten my Curlix here. Now, we had this set up ahead of time for you guys. My hands. If we were doing this in a patient room, we would want to wipe down the surface ahead of time. So, got my gloves on. And I'm going to do my packing. So, Miss Palmer, do you have that other cotton tip applicator that I could have?
I do.
Okay.
Why do you need it?
So I want that so that I can do my packing. Because I can't just stick my fingers in there and get all of the packing where I want it to. Thank you. So this is going to help me get to those areas underneath the skin that we can't completely visualize and be able to have the dressing adhere to the tissue there. Because what we're doing with a wet to dry dressing is our goal is mechanical debridement generally. So what we're going to do is keep, we want to get in contact with all of the tissues there. So I did break this.
What should you do, Miss Cammy, about the tunneling?
So the tunneling you would pack as well.
Oh, you have to go inside the tunnel?
Yes.
Oh.
So this tunneling was not very deep, so I could kind of pack it in addition to doing this here. Sometimes you'll have significant tunneling where you may have to pack down in there quite a bit. But this is another reason it's important to have one complete piece so that you don't lose a piece of gauze in the wound bed anywhere.
I think it would be nice to ask the students why we have to put the packing back into a tunneling open. So I think they should think about that. What do you think, Miss Canby?
I think that is a great question.
Like, what's the reason? Yeah. We always like to know why we're doing what we're doing.
Yes, and not just because the doctor said so.
Right.
Okay. So I've got plenty of packing here. I wanted to make sure it's all touching all of the wound bed there. So if I'm a nervous student, what do I do here? Do I go, ah, and pull it off, like pull it away to cut it? No. So I just want to keep it here, and then we can cut the gauze at the length that we need it.
Again, if this was a sterile dressing, a sterile surgical dressing, like Miss Blackmore's going to show you, you would have to use sterile scissors.
That's right.
And
sterile
those are
scissors.
not sterile. So remember, this isn't a sterile wound.
Not a sterile wound. So you guys can see there that my dressing is covering all of the wound bed there. And our little tunnels were kind of teeny tiny, so as I was packing in there, which I should have explained, I was kind of pushing down in that area a little bit to make sure that I was including them in the packing. So our wound has been packed, so that's the wet. That was the wet gauze. And now I'm going to do the dry gauze. So we're going to say Mr. Butts here had a lot of serous drainage from his wound. So I'm not going to just put one gauze on there. Because one, we have this serous drainage, and two, we have a wet dressing underneath there. Now it's not soaking wet, which I also didn't show you, because you want to make sure that if your gauze is super saturated, you wring it out a little bit. But
Should
it's
feel like a
moist.
damp sponge, right,
Right.
Miss Canby?
Yes, a damp sponge.
Good.
So I'm going to put a couple of layers of gauze on here. All right, so now we have that, and we can tape our dressing. And look, so I don't have to struggle with the tape pieces because I already have them ready for me. And this is a tricky area to tape because, as you can see, it's going to be falling right into the crack here. So instead of just going straight across, I'm going to have my tape so that it moves with the body.
I think that will help so stool doesn't get up inside that wound, right, Miss Canby?
Yes, that's very good, Miss Palmer.
It's very close to the anal opening, so I could see how stool would go into the wound.
Yes, that's right. And you also want to be careful with these types of patients who have these dressings on their bottoms, that when you're putting them on a bedpan or you're moving them up or down in bed, you're not, the friction is not causing the dressing to be removed.
Okay.
Okay, so there we have it. We have a nice, clean dressing change.
Excellent.
Of course, I would gather my supplies and wash my hands afterwards, thank the patient for letting me participate in their care, and then go outside and debrief with my clinical instructor and tell everybody how super awesome I did at clean dressing changes.
Excellent. So just to verify what I need to put in DocuCare, Miss Canby, I just want to make sure I'm not missing any pieces.
Okay.
So I need to include the length, width, and depth of the wound.
Yes, so length, width, and depth. So that was length, width, and depth. The tunneling, any drainage, and sometimes you'll see what they want to know what the wound bed looks like. So was it pink? Was it red? Was it white? I didn't mention. Did I mention deep tissue injuries?
No.
Miss Palmer, and that's my mistake. So one thing I didn't discuss when we were looking at our staged wounds is our deep tissue injury. So this is what we call unstageable. So anytime your wound is black like this or necrotic, that's unstageable. Okay.
Okay.
All right.
Well, thank you for teaching me today. I can't wait to try this on a live patient.
Yes. Well, I am sure that you will do fantastic.